Hi, I'm Myra Ludinger. I'm a doctor of nursing practice, board certified primary care adult gerontology nurse practitioner, and menopause specialist. Today, we're going to talk about beyond the hot flashes. 5 essential truths about midlife health everyone misses. First one, the taboo of the silent transition. While hot flashes and night sweats dominate the mainstream conversation about menopause, there is a silent transition occurring in the pelvic region that remains a taboo. Changes affecting the vulva, vagina, and urinary tract are incredibly common, yet they are rarely discussed with the same urgency as vasomotor symptoms. Statistics show that vulvovaginal atrophy, a primary component of this transition, affects between 20% and 84% of menopausal women. Too often, these symptoms are dismissed as, oh, that's inevitable, if irritating byproducts of just getting older. However, unlike hot flashes, which often peak and then subside, these changes are progressive. They are part of a specific medical condition known as Genitourinary Syndrome of Menopause, and they require a proactive approach to prevent long-term consequences that can last a long time. For decades, the medical community used narrow terms like atrophic vaginitis to describe midlife changes. Today, we use more accurate and empowering umbrella term, genitourinary syndrome of menopause, GSM. GSM is a comprehensive syndrome caused by the decline in estrogen, and it encompasses far more than just dryness. It represents a systemic shift across the entire pelvic architecture, including the labia, the vaginal opening, the vagina, the clitoris, the bladder, the urethra. And recognizing this as a syndrome is a game changer. It validates that women's frequent UTIs, urinary urgency, and vaginal irritation are not isolated problems, but they are interconnected symptoms of the same hormonal shift. While vaginal atrophy refers specifically to the thinning and drying of the tissue, GSM acknowledges that the total impact on a woman's health and sexual function is tremendous. The use it or lose it reality is backed by science. It may sound like an old wives' tale, but the concept of physical therapy for vaginal health is grounded in solid clinical data. Regular stimulation and activity are vital for maintaining the structural integrity of the pelvic floor and vaginal tissue during and after menopause. Activity, whether self-directed or with a partner, maximizes localized blood flow, which is essential for maintaining vaginal width, length, and tone. For those experiencing severe symptoms where activity is painful, using tools like vaginal dilators under the guidance of a pelvic floor physical therapist can help restore elasticity. Regular stimulation and activity involving the vulva and the vagina promote blood flow to the genital area and natural secretions that help maintain vaginal health. So, reframing sexual health as a component of tissue maintenance removes the shame and emphasizes medical necessity. Staying active is a proactive measure to prevent the tissues from narrowing or losing their elasticity over time. Now, let's talk about lubricants and moisturizers. Many women mistakenly use lubricants and moisturizers interchangeably, but they're so different and they serve different health functions. Vaginal lubricants, these are short acting and intended for use during sexual activity to reduce friction. Vaginal moisturizers, these are long acting products designed to adhere to the vagina mucosa, helping cells retain moisture. For best results, they should be applied regularly, every 1 to 3 days. Choosing the wrong product can actually backfire. Atrophic tissues are highly sensitive, so using products containing perfumes and dyes and warming agents or spermicides can cause contact dermatitis and worsen irritation. Simple. Low-cost natural oils like coconut or olive oil are often better tolerated for regular use than flavor or complex commercial lubricants. Vulva care do's and don'ts. Do wear 100% cotton underwear and sleep without underwear to allow for airflow. Wash the vulva with water only or very mild fragrance-free soaps. Apply a preservative-free emollient like plain petrolatum to improve barrier function. Another very powerful tool is low-dose local estrogen. Fear of hormones prevent many women from seeking the most effective treatment for GSM. Low-dose vaginal estrogen therapy is fundamentally different from systemic therapy. Because it is applied locally, estrogen levels typically remain within the normal postmenopausal range. The safety profile makes it a viable option for nearly all women, including those with cardiovascular disease and sometimes even breast cancer. It is even considered for survivors of breast cancer, just like I said, including those taking aromatase inhibitors or selective estrogen receptor modulators, who often feel they have no options for relief. In a large observational study, no increased risk of endometrial cancer, breast cancer, or cardiovascular disease was seen with vaginal estrogen use. While vasomotor symptoms often improve over time, GSM generally worsens with prolonged estrogen deficiency. Local estrogen therapy restores blood flow and tissue thickness, and because it is minimally absorbed, it provides a game-changing solution without the risks associated with systemic hormones. Incontinence. Incontinence is common but never normal. Urinary incontinence is a significant social and clinical burden, with prevalence rates reaching up to 60% for mild cases. We must challenge the pad culture that suggests women should simply cope with leakage. Pads are coping mechanisms, not a treatment. Non-surgical interventions are remarkably effective. Weight loss. In overweight or obese women, losing weight can reduce frequency of incontinence episodes up to 70%. Pelvic floor physical therapy. Strengthening the levator and ani muscles, the Kegels, also has shown to provide a 70% improvement in symptoms. The 3-day urinary diary. Before your clinical evaluation with your provider, keep a 3-day diary tracking fluid intake, the timing of voids, and leakage episodes. This tool provides your provider with some objective data to individualize your treatment. When we move from coping to treatment, we reclaim quality of life. Pelvic floor PT and bladder retraining are highly effective medical treatments that address the root cause of the issue rather than just masking the symptoms. In summary, the silent transition of midlife health requires a proactive assessment. Unlike other menopause symptoms that may resolve on their own, the signs of GSM are progressive and generally worsen without treatment. Why do we accept silent suffering for conditions that we have treatments? From adjusting your vulvar hygiene to starting pelvic floor or utilizing low-dose local treatments, the tools to reclaim your comfort are within reach. If your quality of life is on the line, isn't it the time to start the conversation? Talk to your healthcare provider to see if any of those options are right for you.